So the first definition of obesity was that obesity or overweight are defined as abnormal or excessive accumulation of fat in body to an extent that it is harmful for health. Measure weight. So we measure obesity on surrogate measures which are measuring weight, but we are correlating with the fat in body, and the common measures we use are body mass and central adiposity. So obesity is now considered as imprecise term because it is defined on the basis of weight and height and not on the direct measurement of fat. It does not convey the health risks related to obesity since the definition is based on anthropometric measurements. It is not an actionable term. It is also associated with great degree of stigmatization. So the new term now proposed is adiposity-based chronic disease, or ABCD is the new term proposed by AAC in 2017. And this is a more precise term or more actionable term. It explicitly identifies obesity as a chronic disease. It also alludes to the precise pathophysiological basis and avoids the stigma and confusion related with the term obesity. And now this has been adopted by most of the organizations globally. This was the recent position statement from European Association for Study of Obesity talking of ABCD. And now most of the organizations accept obesity as a frequent, serious, complex, relapsing and chronic disease that represents a major health problem. Now, whenever we are looking at obesity, we know that it is associated with a number of comorbidities and complications. And this slide actually enumerates only some of the important ones. Now the list has more than 230 complications or disease conditions associated with obesity. But I am restricting to the cardiovascular and metabolic comorbidities or complications associated with obesity. Now this was 2021, IDF estimates that we got, and we had estimation of number of people living with diabetes in India at 74 million. But recently we had, ICMR INDAB data published in Lancet from Dr. Mohan's group, and I must thank Dr. Mohan for giving me slides for this presentation. So this is the ICMR INDAB study, and now the estimated number, estimated number of people living with diabetes in India is 101 million. But another important thing that has come up in this study is the high prevalence of obesity. It is missing some slides, I don't know why. Should not be blanks. Sure, anyways, I will continue, I will manage. So, what we got from ICMR in diabetes that there is a high prevalence of diabetes in India, and the number is pegged at more than 101 million people living with type 2 diabetes. Another interesting thing is that we have very high prevalence of obesity in India now, and almost 30% of the adult population is obese, and there is higher number in the urban population as compared to the rural population. Now another interesting thing is that we have even higher percentage of people living with central obesity. The overall prevalence in adults is about 40%, and urban people more than 50% have central obesity. Now if we look, there was another publication from Dr. Mohan's group, ICMR entire study, when they had completed the prevalence in 15 states. And they had given a list of all the states with different prevalences of diabetes. Now the interesting part was that the states that had highest prevalence of diabetes also had the highest prevalence of obesity. So there is a strong correlation between, this was the study with 15 states. Again, I don't know why these slides have gone missing, but never mind. So there is a strong interrelationship between type 2 diabetes and obesity, and there are a number of studies which have shown that people with overweight or obesity are at greatly increased risk of developing type 2 diabetes. And two are so commonly seen together. The term diabesity was coined way back in 1973, and for every 1 kilogram gain in weight, there is 4.5% risk in the increase in the risk for developing diabetes. Now, this slide shows that as the BMI goes up, there is also increase in the risk of high blood pressure. The higher is the BMI, higher is the prevalence of hypertension. Now, obesity is associated with increased risk of atherosclerosis, we know, and coronary artery disease, and partly it is due to the strong association between obesity and atherogenic dyslipidemia, which is characterized by high TG, low HDL, and normal or high LDL level, and increased concentration of ApoB. Dysregulation of lipoprotein metabolism in obese subjects may be due to combination of overproduction of VLDL, decreased catabolism of ApoB containing particles, increased catabolism of HDL. Again, one abnormality of lipid metabolism, which is closely associated with obesity. And these abnormalities actually may be consequent to the increased insulin resistance and increased visceral fat. Now, this slide shows that as the BMI starts going, can you see the cursor here? So, as the BMI starts going above 18.5, the risk of diabetes, blood pressure, dyslipidemia, all goes on increasing. And these three are the most important core determinants for increasing the risk of cardiovascular disease. So obesity, especially the visceral obesity, causes insulin resistance and is associated with dyslipidemia, hypertension, abnormal glucose metabolism, and diabetes. Obesity contributes directly to the incident cardiovascular risk factors, which I just showed you. It also leads to development of cardiovascular disease and cardiovascular disease mortality, independent of the increase in risk of cardiovascular risk factors. And abdominal obesity is a cardiovascular risk marker, which is independent of the body mass index. So central obesity is an independent marker as compared to the overall obesity also. So obesity is a strong risk factor for development of CVD because patients with obesity experience CVD events at early stage of life, and they have to live a greater period of their life with CVD and its complications. They have shorter average lifespan as compared to people who do not have obesity. Again, if you look at the 26-year incidence of coronary artery disease in men, this was a long-term follow-up study. Again showed that as the BMI goes up, the risk of getting a coronary artery disease in men was increasing, and so is the case in women. So as the BMI goes up, there is increasing risk of getting coronary artery disease as well as coronary artery disease mortality. This is data analyzed from two large studies, the Nurses Health Study and the Iowa Women's Study, which had follow-up of almost 20 years, and they looked at the risk of CVD in women who had high BMI versus who had high central fat or the high central obesity. So if you look at the risk was risk in women who had high BMI and low central obesity was lower than those who had high central obesity and low BMI. So central obesity contributes significantly to the increased risk of developing coronary artery disease, And this slide again shows that as the BMI starts going above 25, there is increasing risk, which is there is linear increase in the risk of developing cardiovascular diseases related mortality. And this was another study by George Gray, who is considered father of obesity medicine, who looked at the risk of developing mortality in relation to BMI, again showed that as the BMI starts going up, there is increased risk in the cardiovascular mortality. Now, all these figures you are seeing, 25 as the cutoff for normal BMI, 30 for the, overweight, and more than 30 stage 1 and stage 2 obesity. For Indian people, we have lower cutoffs of BMI because we have more central obesity, we have more percentage of fat in body, and that is why we develop the cardiovascular risks and complications at lower levels of BMI as compared to Caucasian population because of the excess central fat or excess ectopic fat. And that is why we define overweight as anything upwards of 23. 18 to 23 is considered normal BMI. More than 25 is considered obesity. Now this was another interesting study which was published very recently, and this looked at the association of body mass index with lifetime risk of developing cardiovascular disease. And this study looked at the association of BMI and CVD mortality and morbidity in pooled individual data from multiple studies, 10 large US studies, and they classified the people in the age groups 20 to 40, 40 to 60 and more than 60. And these people had follow-up data for almost 50 years, between 1964 to 2050. And at the baseline, none of them had cardiovascular disease. And if you look at the follow-up data, data from this study, compared to people who had normal body mass index, the hazard ratio of getting cardiovascular disease or cardiovascular death was almost 3.14, and this was seen both in men and women. And they also estimated the vascular aging. So compared to a person with normal BMI at the age of 35 years, the vascular age for a person with high BMI was seen at the 20 years. So there was almost 15 years, premature vascular aging if you compare the person at 25 with obesity versus 35 years without obesity. And this was very significant, indicating that there is very early atherosclerosis. Now, what causes this metabolic state in obesity? First thing we have to understand is the fat storage. So, whenever there is excess energy that we have, it is largely stored as triglycerides in the adipose tissue, white adipose tissue. And these triglycerides are released during the time of need, whenever one is exercising or fasting or starving. But there is a limit up to which the white adipose tissue can store fat. And it stores fat by two methods. One, by increasing the number of white cells, that is the hyperplasia. And second is increasing the size of white cells, adipose tissues, adipocytes, which is hypertrophy. Now, once there is increase in the size of adipocytes, that means there is accumulation of more fat inside every adipocyte, there is increased stress within the cell, which leads to inflammation and formation of free radicals. And these adipocytes become dysfunctional. So there are two ways you are storing excess fat. One is storage within the same number of adipocytes, leading to inflammation, leading to spillage of free fatty acids and development of insulin resistance. On the other hand, some people will store by increasing the number of adipocytes, where the inflammation will not happen. They will become obese, but they will not get the complication or risk associated with obesity. And this is called metabolically healthy obese state. But now there are enough studies to show that this is only a transient period between normal state with obesity going on, progressing to the dysfunctional state or dysmetabolic state with obesity. There are at least 3 distinct mechanisms which have been linked or proposed to have linked with obesity and insulin resistance and development of diabetes. One is the increased production of adipocytokines, which include TNF-alpha and interleukin-6, RBP4, all leading to increase in the risk of insulin resistance. Second is the ectopic fat deposition. Earlier we were thinking only of liver and muscle. Now we know it is liver, muscle, pancreas and heart also. And third is the mitochondrial dysfunction, which is evident in many studies by decrease in number of mitochondrial number and also dysfunctional mitochondria. Now mitochondrial dysfunction may be the key defect which underlines not only the development of insulin resistance but also development of beta cell dysfunction leading to progressive decline of insulin secretion. And there is now possibility that both obesity and diabetes share a common underlying defect, and defects which favor the progressive weight gain also favor the development of beta cell decompensation. So what happens is that once you have sustained increased intake of calories, there is sustained exposure of cells to excess amount of nutrients, more than the requirement of the cells. And this excessive nutrients lead to damage to the cells, leading to inflammation within the cells, increase in endoplasmic reticular stress, increased formation of free radicals, mitochondrial dysfunction, going on to development of cascade of chain reactions, leading to development of insulin resistance and beta cell dysfunction. Now, what causes the cardiovascular risk in obesity? I have talked about the associations. I have talked about the strong association between obesity and this metabolic state leading to development of diabetes. But how does everything else fit into the picture? So I will show you a very simple slide before I go on to that. The new concept I talked about, the adipose-based chronic disease. According to this whole concept, now the center stage is adipocyte or obesity. In people who have genetic predisposition and are exposed to the environmental factors conducing to development of excess fat accumulation in body, this excess fat accumulation leads to dysfunctional fat and abnormal ectopic accumulation of fat. And once this happens, accumulation of fat exceeds the threshold for normal level of fat, because of the sheer weight of fat, there are biomechanical complications. There are dysfunctional fat leading to changes in the biochemical parameters, leading to the components of metabolic syndrome. There is increased spillage of free fatty acids, leading to development of insulin resistance, going on to develop pre-diabetes, diabetes and complications of diabetes down the line. In addition, further insulin resistance leads to development of metabolic syndrome and components of metabolic syndrome, which include dyslipidemia, hypertension, pro-inflammatory state and so on. And this further leads to increased risk of developing the LV dysfunction. We know now heart failure is again one component, asymptomatic coronary artery disease, atrial fibrillation and so on. So the whole gamut of disease actually is centered around adipocyte. And this is a simple slide which explains everything. So this looks very interestingly simple, but actually it is a simple slide. You have to follow the track. So what happens is, once there is adiposity, there is increased adipokine and adipocytokine synthesis, which leads to pro-inflammatory state and development of insulin resistance, increase in insulin levels and downline diabetes. Now, second thing is, there is increased release of free fatty acids which get deposited in ectopic sites, leading to conditions like dyslipidemia and NAFLD. Also, there is increased activation of RAS, there is increase in sympathetic activity, and this all leads to development of hypertension and increased pulmonary hypertension. There is also mechanical stress, there is compression of the renal tissue which further enhances the whole problem, leading to increased risk of developing coronary artery disease because of diabetes, dyslipidemia, hypertension, increased sympathetic activity on one side, and increased risk of developing strokes and chronic kidney disease. So whole thing is starting from adiposity. So adiposity is the core culprit for developing all the cardiometabolic risk. Now, once there is this metabolic state, there is metabolic syndrome and hyperinsulinemia and so on. This leads to inflammation in the myocardium also, leading to hypertrophic cardiomyocytes. There is fibroblast proliferation, and there is, ultimately leading to the apoptosis, leading to development of heart failure and arrhythmias and sudden. And there are multiple factors which have been shown to contribute to this state. So in a nutshell, genetics and environmental factors lead to a situation which leads to development of ABCD or so-called adiposity or obesity. Now at this stage, one can be insulin sensitive or insulin resistant. So if there is insulin resistance and increased free fatty acid turnover, leads to development of pre-diabetes, diabetes, metabolic syndrome, pre-hypertension, hepatic steatosis, and down the line, development of diabetes, hypertension, NASH, increased risk of CVD events, and so on. The people who are insulin sensitive, again, during the course of life become insulin resistant and are exposed to development of these risk factors. Now, those who are insulin sensitive, again, have the risk of developing biomechanical and psychological complications. Now, once this has developed, this whole thing, the further aggravation of the risk for cardiovascular disease happens because of hypertension, diabetes, and NASH, leading to increased risk of strokes, failure, and myocardial events. So we are treating all these diseases, but we forget to treat obesity. If we intervene at the level of obesity, possibly we will not be seeing all these diseases and we will not need to treat all these. So with that, I come towards the end of my presentation. This is just one study which looked at treatment of obesity, medical management versus bariatric surgery, and again showed that significant weight reduction with bariatric surgery was associated not only sustained remission of diabetes but also risk reduction for developing macrovascular complications. And now we have medical interventions. There are a number of studies showing that even modest weight reduction is associated with significant reduction in the risk of comorbidities, cardiovascular risk, and more than 15% reduction is associated with a reduction in cardiovascular mortality and diabetes remission. We earlier had treatment options in terms of bariatric surgery because with medical management we were hardly able to achieve more than 10% weight reduction. But now situation has changed with newer GLP-1 receptor agonists and dual agonists, we are able to achieve up to 25% reduction with newer molecules, and in times to change everything is likely to change. So I will not go into the treatment options. I will just conclude my presentation. So obesity is an important precursor for developing cardiometabolic diseases. It is an important risk factor for cardiometabolic diseases, and weight reduction of 10 to 15% can help reducing cardiometabolic risk and cardiovascular mortality. With that, I conclude my presentation. Thank you so much. Thank you.